Welcome to Why Health Equity and Access to Care is Important for All, presented by Dr. Dineo Khabele. Dr. Khabele is a physician, surgeon, scientist, educator, and advocate. As a physician and surgeon, she specializes in treating women diagnosed with ovarian and other gynecologic cancers by providing individualized and compassionate care. As a recognized physician scientist, she has extensive clinical and translational research experience in gynecologic oncology with a focus on ovarian cancer. Dr. Khabele has generously presented on the importance of health equity for us in the past, and we are excited that she will be joining us again, as equitable, high-quality care is critical for all individuals and is a top priority at OCRA. Thank you, Dr. Khabele, for your wisdom and willingness to share your perspectives on this important topic. Dr. Khabele, I turn it over to you now. Thank you.
Hello, everyone. I'm delighted to speak today at the 2023 Ovarian Cancer National Conference, Uniting for Hope. My name is Dineo Khabele. I'm a gynecologic oncologist and professor and chair of the Department of OBGYN at Washington University in St. Louis. And I'm here today to talk about racial inequities in ovarian cancer care, a focus on Black women. Here are my disclosures, and the opinions expressed are my own. So ovarian cancer care, you're going to be talking about this throughout the conference. And I just wanted to talk about the different areas that we focus on as clinicians. If we could spend most of our time really talking about preventing ovarian cancer, and risk reduction has become really, really important, particularly in understanding some of the genetic underpinnings of ovarian cancer and identifying high-risk populations who would benefit from interventions. We're getting better at diagnosing ovarian cancer, but unfortunately, we're still not able to really find that perfect tool, or any tool, as a matter of fact, to date, to diagnose it before it starts, or to diagnose it early. Most patients are diagnosed at advanced stage of disease when it's already spread. We're doing better with treatment. Patients diagnosed and people diagnosed with ovarian cancer are living longer, and we're paying attention to survivorship along the way. And then we really do have to continue to pay attention to symptom management and palliative care. And ultimately, too many women end up succumbing to ovarian cancer. And so there's lots of research that we have to couple with our clinical care to make a difference in people's lives. One of the areas that becomes really important when we talk about ovarian cancer inequities is that although ovarian cancer is more common when you compare Black women to white women, the overall risk is about 1 in 78, and it's much more common amongst white women, but Black women have worse outcomes. Despite these statistics, we know that equal care leads to equal outcomes for Black women, and that's an area that we really have to pay attention to. And as we think about the words of the Reverend Dr. Martin Luther King Jr., of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. And so with my talk today, I'm going to intersperse and interweave stories and vignettes, because I think what's really important is making sure we understand the humanity of what it means to be diagnosed and treated with ovarian tumors and ovarian cancer, and really educating ourselves within the medical community, but also within the public, that this is really important. So this first vignette is of a 48-year-old Black woman who sought care for about 12 months, complaining of abdominal pain and pressure. She had felt a mass on her own belly, and she was told she had fibroids, which was really something that's very common amongst Black women. She ended up eventually getting imaging that showed a very large complex mass, almost as if she was 9 months pregnant. And she had an elevated CA-125. And at that point, she was referred to see a gynecologic oncologist. But clearly, in this case, her diagnosis of ovarian cancer was delayed, and she ended up being treated with standard of care surgery, resection of this large mass intact. It didn't spill. It ended up being a mucinous adenocarcinoma stage 1, and she's alive with no evidence of disease. She's grateful to be alive, but really there was almost a year of delay in her diagnosis. This is another patient who's a 39-year-old Black woman who's in perfectly good health. She was very vigilant about yearly visits to her gynecologic and primary care physicians. She had a strong family history of breast and ovarian cancer. But really, this really wasn't brought up in her visits until a cousin was diagnosed with ovarian cancer. And the cousin had a BRCA1 mutation, and then the patient underwent cascade testing, and she herself was found to have a BRCA1 mutation and eventually underwent a risk-reducing hysterectomy, bilateral salpingo-oophorectomy, BSO, after she was done with childbearing. So please keep these vignettes and stories in mind, and we'll come back to why stories matter. So racial inequities in healthcare exist and persist, not just in ovarian cancer care. It's been well publicized, established, studied that Black patients are less likely to receive appropriate medication, cardiac medication. They're less likely to undergo coronary artery bypass surgery. They're more likely to be diagnosed with late-stage breast cancer. They're more likely to receive a lower quality of basic clinical services, such as intensive care. Nationwide, Black patients die at 2.5 times the rate of white patients, white people within the medical establishment. And here are the statistics. This is deaths per 100,000 people by race or ethnicity. And, you know, in my area as chair of OBGYN, these statistics really concern me. In pregnancy-related deaths per 100,000 live births, Black women are, 3 to 4 times more likely to die than white women. And you can see the statistics for American Indian and Alaska Native women, who are 3 times more likely to die in pregnancy-related death than white women. The leading causes of death by sex amongst Black and white patients, this is for people populations, this is in 2016. Cancer ranks number 2, secondary to heart disease for both males and females. And the death rates are higher amongst Black people compared to white people. And when we talk about below the belt cancers, gynecologic cancers, which include cervix, cancers of the womb, this is depicted here, that are the most preventable, cancers of the lining of the uterus or endometrial cancer, which are becoming more deadly and are the most common, and cancers of the ovary, which still have the worst prognosis. These are the cancers that show high racial inequities. In the blue is all races, in the red is white patients, and in the green, Black patients. So you can see there's a poor prognosis across the board for Black women diagnosed with gynecologic cancers. The COVID pandemic did not help. And COVID death rates by race and ethnicity, Black people, particularly those over the age of 65, were more likely to die from COVID-related complications than other populations. And this is one of the publications that showed that. And there was a decreased likelihood to receive treatment with remdesivir, which is one of the drugs that was used to treat patients at the height of the COVID pandemic. And so again, this is more evidence that there are inequalities in outcomes and inequalities in treatments received. We are now 20 years after the National Academy's publication on unequal treatment, confronting racial and ethnic disparities in healthcare. This is a week that the National Academies are going to start announcing the people who have entered into the Academy. And unfortunately, this publication remains and persists as a problem in the United States as far as unequal treatment and inequities in healthcare. When we look at this chart, the y-axis is the quality of healthcare, and the x-axis is comparing non-minority to minority populations, and this includes Black and Latino and Native American. And so you see that there are differences, but there are also disparities. And what's really, really important is in an era of personalized and precision medicine, we really want to be here at this very top where we talk about the clinical appropriateness based on molecular features of a tumor or based on a person's underlying medical condition, as well as the patient preference. That's the area of medicine that's really important and where we really need to be. And unfortunately, a lot of what we're dealing with is disparity in the ecology of healthcare systems and environmental factors, such as the type of insurance a person has or what zip code they live in. And then we have this area of discrimination, biases, stereotyping, and uncertainty that lead to disparities. And this factor of disparity is what is a gap that we really need to close, and have the difference really being about what's important for an individual patient based on the clinical appropriateness and their desires. So when we talk about disparity, some of the things that affect patients diagnosed with ovarian cancer, and this was adapted from our SGO task force that I participated in 2014. We published this during this time, and this is now almost 10 years ago, and some of this information really has not changed. When we look at a disparity, we're looking at really ecological and environmental differences in whether you're in a low capacity geographic region, whether you're in a place that's really rural where you don't have an HE1 oncologist, or whether you're in a very urban area where you don't have adequate insurance, and or you don't have, you're a city hospital maybe that doesn't have the specialists mostly dealing with primary care, and you don't have the tertiary care and specialists who could take care of your patients. And so with this disparity, are there ways that we can partner with specialized and regional referral centers to provide the care? And we saw some of this start to happen in the height of the COVID-19 pandemic with some of our telehealth capabilities, and maybe some telemedicine could help with this. Again, it's very similar with low volume hospitals in the catchment area. These strategies could be used. Inadequate insurance policies and lack of Medicaid coverage of clinical trials has been really a big issue, and expanding Medicaid has helped with access to care, and expanding Medicaid coverage to cover patients who are enrolled in clinical trials will enhance our ability to offer trials to everyone. And not the focus of this talk, but we understand that a lot of the new treatments that are coming down the pike have, especially the kind of precision medicine, targeted molecular treatments, have high burdens of financial toxicity, even with patients who have insurance. When we look at physician factors, which is something from the Institute of Medicine and National Academies, we look at something that makes a difference and causes disparity. If you are being treated by a low volume surgeon who really doesn't do a lot of procedures, doesn't do a lot of ovarian cancer debulkings, again, partnering with highly specialized regional and referral centers where a surgeon can make a diagnosis and then refer to the ultra specialist to provide that expertise. Education and awareness are important as well. Understanding that in ovarian cancer, from a surgical standpoint, it's important, and it really makes a difference in outcomes if the surgical procedure gets all the tumor, the visible tumor, out, and that you perform an R0 resection, meaning no visible residual disease. We have huge disparities in diagnosing and treating ovarian cancer in this country because literature shows that many patients are diagnosed by non-gynecologic oncology specialists who don't have the expertise. And again, the strategy is similar for these two. And then with physician factors, this is something I really pause with and spend a lot of time in my advocacy work and education with my own colleagues, because many of us have biases in clinical decision making. And so it's important to have ongoing training amongst ourselves to incorporate topics about health disparities, health equity, and research topics, not only into our national meetings, but into our educational programs within the institutions we work. And then a lot of the work that I do is to help to train a more diverse workforce, and of course, directly encourage and offer clinical trials to all of our patients, since that is the standard of care for treating ovarian cancer. And then, of course, this is multifactorial. Many patients don't have access to healthcare, and the disparity is due to a low socioeconomic status, lack or limited insurance, lack or limited education, lack or limited income and resources, transportation. All these things start adding up. And so a strategy is to be really comprehensive in developing programs to reach populations who are underserved so that care is expanded. There are patient factors such as fear, and fear is not limited to patients who are Black or Hispanic, but everybody has high levels of fear when they're diagnosed with a cancer. And then there are high levels of fear interacting with any kind of medical profession, but the fear is heightened in certain minoritized populations. So what can we do to increase awareness and education and provide support in peer groups to counteract that fear? There's understandably lots of mistrust in the medical establishment, and I'll talk about that a little bit more. But I believe the onus is on us within the medical establishment to increase culturally appropriate programming and care to patients. So amongst the stereotypes or biases, I'm coming back to those first two patients that I presented. There are lots of stereotypes within the medical profession about a pelvic mass in a Black woman is most likely to be a fibroid, a benign tumor. So you can make this biased assumption that most Black women who come to you with a pelvic mass are going to have fibroids and not ovarian cancer. And whereas that might be the case, the onus is on us to make sure that we are truly performing the appropriate workup and making sure we're not delaying a diagnosis of ovarian cancer, similar to the patient I presented earlier. There is an assumption and a stereotype that BRCA 1 and 2 mutations are not common amongst Black women. And historically, when these genetic alterations were discovered and studied, they were not studied as often in populations, in a broad range of populations. And now we know that BRCA mutations are common or exist in all populations. And there may be certain types of mutations that are unique to certain geographic areas of the world, including Africa and the Caribbean. And so Black women and families that have breast and ovarian cancer in multiple generations should be tested for evidence of these mutations in their families. And then if a Black woman is diagnosed with ovarian cancer, standard of care is to offer genetic testing to that patient, which is what we would offer to anybody. And then there's a stereotype that Black women are not willing to undergo treatment or radical treatment, like a hysterectomy or chemotherapy. And there are some cultural hesitations to some of the treatments. But I think that it's on us to provide really culturally sensitive awareness and education and ask about why, the underlying reasons why, and address those concerns and educate about the importance of the many aggressive treatments that we have, including radical tumor debulking and multi-agent chemotherapy that have made a difference in ovarian cancer survival for many, many, many patients. Amongst the patients, depending on what part of the country you live, when I moved to the South, there was, for the first time ever, I heard this local myth, and I think it's in many places in the country, that if you have surgery, if you open up a person, when air hits it, it will spread. And this is folklore with little bits of truth in it, right? If somebody comes to the doctor and they have metastatic ovarian cancer, and then they undergo surgery, it's widespread ovarian cancer, but it's not the surgery that all of a sudden made the cancer spread. The cancer was discovered, metastatic cancer was discovered at the time of surgery. And so acknowledging folklore and educating communities about the importance of surgery in ovarian cancer survival is really key. And then cancer as being a death sentence. When I was a medical student over 25 years ago, coming on 30 years, we didn't even say the word cancer. We did not say the word cancer because many patients succumb to disease within a year of diagnosis. And now we know that saying the word cancer doesn't make it so. Actually, acknowledging the word cancer helps us address the problem. It helps us treat cancer. And as we see, fast forward many decades, that people diagnosed with ovarian cancer are living longer and longer with treatment. And without treatment, that impacts survival for sure. So educating communities, patients, and families about the advances that have been made in ovarian cancer care and in cancer care in general. Then the other stereotypes that really come along with different faiths and different religions, that my faith alone will heal me, or I won't claim it, I won't name it. So really working with church communities to increase awareness about a diagnosis of cancer, particularly ovarian cancer, and that we do have treatments available, and then partnering with your faith leaders so that there's this partnership with the faith that a person has and with the physician. And then, of course, there's a stereotype about medical professionals. I don't trust doctors. I don't trust big pharma. I don't want to be a guinea pig. And we saw a lot of this happen, related to the COVID-19 pandemic. And I think that there's a lot that we can do as physicians and healthcare providers in the medical establishment to really increase trust. But it also comes back to partnering with communities and educating people and having our partners in the communities carry the message. So it's not just us from the medical establishment talking about why it's so important to get treated. And so stories matter in medicine. And why do stories matter in medicine? Well, one of the first things that happens when you come see a doctor is that we ask about the history of the present illness. This is the tool we use to explain, to understand, and to interpret medical conditions and disease. We take a history, the chief complaint, a chief concern that the patient has. How long did they have this concern? What were their symptoms related to it? Do they have a family history, particularly as we talked about, of breast or ovarian cancer? What are the other symptoms they're experiencing? And we ask these questions prior to performing a physical examination. This is what we traditionally are taught to do in medicine. This requires listening It requires interpreting, it requires comprehension, it most importantly requires trust, because this history helps us make a diagnosis, offer treatment, and establish a therapeutic relationship with the patient. But what if you as a physician or me as a physician doesn't believe the story, or the patient who's the storyteller? That already sets up a scenario of distrust. And we have to get beyond this to do better for patients. So I'm going to switch gears for a second and give you a few scenarios, vignettes, a few stories. And this section of my talk is called Speculum, Syphilis, Cervical Cancer, and Serena Williams C-section. So bear with me, please. The modern speculum was is an important part of the history of gynecology. It's an integral part also of Black American history. And I'll start with a case narrative. This is an 18-year-old Black woman who had given birth to a child 2 months previously. And since that time, she had been unable to hold any water, meaning she was just leaking water constantly, leaking urine. Her bladder was destroyed, leaving an opening between the vagina and the bladder at least 2 inches in diameter or more. This was a fistula. And this used to occur and still occurs in many parts of the world from obstructed labor, prolonged labor when giving birth. And Dr. J. Marion Sims was the gynecologist who took care of this patient. And that was before the days of anesthetics. And this is directly quoting from his biography that he wrote. That was before the day of anesthetics. The poor girl on her knees bore the operations with great heroism and bravery, had about a dozen doctors there to witness the series of experiments I expected to perform. All the doctors had seen my notes often, examined them, and agreed I was on the eve of a great discovery, and every one of them was interested in seeing me operate. So this is in the history of what people have recognized from this period of time, which was during the time of slavery in the United States. And this young woman, the story I told was of Lucy, but this is a picture of another one of the enslaved women who was operated on by Dr. J. Marion Sims, pictured here. This is Anarcha, who underwent 30 operations for fistula repair. And this is the Sims speculum that we use to date in the field of gynecology to view the vagina. And this is a quote from the story of his life that I will not read. He designed many of the instruments that we use today, but as you can imagine, many Black people who know of this history are very skeptical of gynecologists if you know of this history. So how do we as gynecologists overcome this history? So I'm going to fast forward from the 1840s to the 1930s. This is the Tuskegee study of untreated syphilis in the Negro male. And this is relevant to the patient in this country as a Black person who gets nervous about vaccines, who gets nervous about any kind of clinical trial because of the history of this public health study that went on for 40 years. And so people will just say the word Tuskegee, and that is of this particular study. This was a study of 600 Black men, 399 had syphilis. They were diagnosed with syphilis. They were not given syphilis. They had syphilis versus 201 men without syphilis. There was no informed consent for this particular clinical trial. And this trial has really changed how we perform clinical trials in this country. The men thought they were all being treated for bad blood. And in exchange for taking part in the study, they received free medical exams, free meals, and burial insurance. And although the project was supposed to last 6 months, it went on for 40 years. In 1972, the study was halted after an Associated Press article, and a $10 million settlement was reached. Tuskegee Health Benefit Program was established for the wives, widows, and offspring who were then added for the men and their wives, widows, and offsprings. The last study participant died in 2004, and the last widow died in 2009. And what's really important is that these men were in the study for this period of time, and you know, after it started in 19 1932, but in 1945, penicillin was a standard of care of treatment, and not a single one of the men in the study received the standard of care treatment. And so this is what happened. It wasn't until 1969 that people started looking at it more deeply, but CDC continued the study. In 1972, there were news reports condemning the study, and finally the study ended. So this is related, fast forward decades, to our skepticism around vaccination, even though not many people really understood that study. You weren't given syphilis. And actually, it would have helped to have had penicillin as a treatment, which was a shot as a treatment for syphilis. And if you look at African American women, they're 10% less likely to receive an HPV vaccine as white women in the catch-up group for HPV vaccination. So we're going through history. 1951, the HeLa is the story of a Black woman's cervical cancer cells and biomedical advances. This is a 31-year-old Black woman who had pain, post-coital bleeding after sex, foul-smelling discharge and a knot in her womb. She was diagnosed with inoperable adenocarcinoma of the cervix and treated with radium implants, which was standard of care at that time. Unfortunately, she died of disease within several months of treatment and within a year of delivering her 5th child. And so this ended up becoming a popularized nonfiction book written by Rebecca Skloot, The Immortal Life of Henrietta Lacks. And this is a picture of Mrs. Henrietta Lacks. These are 2 pictures of her here. Here's a picture of her cells, a beautiful immunostaining of her cells. And her story was made into an HBO movie that starred Oprah Winfrey. And these cells have gone on to be used for many, many, many medical advancements. And just this year, the company that bought the cells came to an agreement with the family. So when we look at 1950s medicine versus today, there was no established practice for informed consent. And this is taken from Johns Hopkins medicine, which is where she was treated. And we've made advances for sure in informed consent and collecting patient samples for research, which is so important for medical advances. But now we have oversight with institutional review boards and IRBs. And then at the time that Henrietta Lacks was treated, very few leading hospitals treated African American patients. Johns Hopkins did treat Black patients, but they were segregated and in segregated wards. And in the 1950s, Johns Hopkins began to desegregate and had a fully integrated ward in surgery in 1959. And by 1973, all inpatient services were desegregated. So the history of Black women in cervical cancer: Black women are less likely to receive HPV vaccination as adults, more likely to be diagnosed with later stages of disease, less likely to receive standard of care, and more likely to die compared to white women. So finally, I want to come back to this century, come up to this century. This is 2017, when Serena Williams had her first baby. And she describes the C-section and the complications thereafter. She was 36 years old. She had a history of a pulmonary embolism and delivered a healthy female by emergency C-section for decreased fetal heart rate. And so her pulmonary embolism had been diagnosed way before, and she'd been treated for it. She'd recovered from it, but she knew what it felt to have a pulmonary embolism, which is a blood clot in the lungs. So the day after surgery, she was short of breath. She was on blood thinning medicines, anticoagulant regimen, and she told the nurse between gasps that she needed a CT scan and heparin, which is IV anticoagulation, blood thinning medicine, right away. The nurse thought her pain medicine was making her confused. but she insisted, and a doctor was performing an ultrasound on her legs. And this is a quote from her: "A Doppler? I need a CT scan, not my legs, my lungs." The ultrasound showed nothing. Eventually, it sent her for a CT, and she had several blood clots in her lungs. And she said, minutes later, she was like, "Listen to Dr. Williams." She's this famous tennis player, one of the richest women in America, and they thought she was confused. So she then had more complications from the procedure, because then she started bleeding. But anyway, eventually she did quite well. She delivered her baby. This was in Vogue in 2017, and I believe she's had her second baby in the past month or so. But this is something that we know. It doesn't matter what socioeconomic status you have as a Black woman, giving birth in this country, 3 to 4 times more likely to die in pregnancy-related death, mainly from cardiovascular disease, bleeding, and pulmonary embolism. And she had both of those things. So there's racial bias also in pain assessment and treatment recommendations. This was a paper published in 2016 where they actually asked white residents and medical students about pain. And there's a prejudice that about Black people's nerve endings are less sensitive than white people's. Black people's blood coagulates more quickly. White people have larger brains than Black people. I mean, these are things that are just awful stereotypes that are even amongst us in the medical profession. So we have a lot of work to do to unpack and undo some of these deep stereotypes. So I don't think it is too far off to say that there is deep distrust by Black women of the medical establishment. This is supported by historical and current data and by personal narratives, people's lived experiences. So all of the women that I presented to you in these little vignettes and these stories received some form of medical care and really standard of care, state-of-the-art care of their time. But how did they receive the care? In what form? How was it experienced and perceived? And were they asked? You know, Lucy, Annika, and Betsy were the enslaved women amongst countless other women, Black women, operated on by J. Marion Sims without their consent. Henrietta Lacks is a Black woman whose body parts, whose part of her cervix were taken, and really contributed to advances in medicine and science, but it was without her consent. And with Serena Williams and countless others, and I personally have also written about this myself from my own birthing experiences, is not being listened to. And I would say that this is not just something that's a problem as far as being kind and nice to patients and improving the patient experience. This comes at a cost. The societal cost of inequities are enormous. They come from, you know, if you have these attitudes and beliefs, it decreases your access to healthcare, quality care, then you have an excess burden of disease prevalence in the population and higher healthcare costs. So even if you don't want to do the right thing, it makes business sense to do the right thing because of the cost. So I really believe in storytelling and narratives because we can change the narrative. We have opportunities to do this. And this controversial statue of Dr. J. Marion Sims was removed from Central Park in 2018 after Black women protested to get it removed. And this has been relocated to the cemetery where he's buried, but Black women really did not want him to be highlighted in the middle of Central Park. And you know, the speculum is an important advance. It's important. It still remains a critical part of what we do as oncologists and as gynecologists. But we also need to perform the speculum exam with skill and with sensitivity and with understanding of the history from where it came. So history is important. And I think it's important, especially in this day and age where we're trying to undo our discussions of history. Because it's important so that we can learn from it. Stories are a critical part of what we do in medicine. It's not just that medical cases, these are not case studies. Medical cases are real people. These are real women that I'm talking about. Even though some of the scenarios have changed, all of the cases, quote unquote, that I've talked to you about today are real people who have real lives, who have real families behind them. And we can change the narratives and the ecology of healthcare if we understand this and engage communities in our own health. This is an example of a peer focus group. It's not an ovarian cancer focus group, but they work in partnership with many of our ovarian cancer advocates and survivors. It's called ECANA, the Endometrial Cancer Action Network for African Americans. And this is a quote from Margie, who's on the steering group, who talks about the importance of making peace with your doctor. And this is part of that trust. A lot of work that I'm interested in, especially in my role as chair of a department, is to do what we can to train more Black doctors, nurses, and healthcare workers. About a third of oncologists are women, but only 2.3% of practicing oncologists are self-identified as Black or African American, and only 7.8% of nurses are Black, despite a population of about 13% of our population being Black. Just last week, I was at Meharry Medical College, and here I am, and every single seat was taken up in this room. Meharry Medical College is a historically Black medical school in Nashville, Tennessee, and all of these students in this room are first and second year medical students. 90% of them are Black women, and I'm hoping that I could convince maybe one or two of them that they'd want to be a gynecologic oncologist and enter this wonderful field, and in which we get to take care of so many people who are diagnosed with ovarian cancer. We also need more people to enter the field of research, and there are studies that are going on to reduce racial disparities and improve outcomes, particularly because Black women have poorer outcomes. And so this was really exciting, announced a few years ago by the NCI. And so I know that we can eliminate ovarian cancer inequities as we are moving towards more advances in ovarian cancer care and research. There are so many things that we're doing around the area of advocacy and awareness, and the Ovarian Cancer National Conference is one of the important places where I know we are shouting to the rooftops to listen to women that ovarian cancer is not silent, that we are shouting to the rooftops that we need more funding for ovarian cancer care and ovarian cancer research. We're educating our communities about symptoms, about some of the symptoms of ovarian cancer that get misdiagnosed or delayed in diagnosis because the bloating and the abdominal pain and the changes in bladder and bowel habits are sending patients to a GI doctor or to a urologist versus to a gynecologist. And we need to look carefully, especially as physicians, and take a detailed family history, because if we diagnose a patient with ovarian cancer, we know standard of care is to perform genetic testing and then cascade testing for the rest of the family, as we see here. And then it's important to perform appropriate exams and tests in culturally sensitive manner, in a culturally sensitive manner. And all of this is because trust is key to what we need. We need therapeutic partnerships between physicians and healthcare providers who have the medical knowledge and lived experience of how to treat ovarian cancer. And this is coupled with patients and communities who support them, about self-knowledge about their bodies and the lived experience from where they come from. So I will close with eliminating racial inequities in ovarian cancer care is imperative. It's imperative. It's the right thing to do. It makes economic sense, and it makes care better for all. If we can figure out how to do well by those patients who are most marginalized and who are on the edges, we will do well for everybody, because we will know how to rise or raise up the quality of care for every single person diagnosed with this disease. And so we fast forward 3 years from when I initially gave this talk, when we had a statement from the Ovarian Cancer Research Alliance about Black Lives Mattering to our community. And we're continuing along this path, and I'm really happy to be a part of the OCRA Scientific and Medical Advisory Board. And I thank you all for the opportunity to talk to you today.